All right, so as I said, they said, so my name is Katie Murphy and I am a heart failure specialist in the Mater. So today I'm going to give a brief overview of the types of cardiomyopathies and talk a little bit about what's normal and what's abnormal, because I think we use a lot of terminology in our practice that you might not necessarily be familiar with. We're going to talk a little bit about family screening because this is something that's becoming more and more common, and it's helpful if you have an idea if your family needs to be screened or not. I'm going to talk about treatments more so to show the massive breadth of things that are available in these days to help you treat your cardiomyopathy and how much is available compared to even 10 years ago. We're going to talk about lifestyle monitoring and then how you self monitor and know whether you're doing well or not, and then just some tips for living well with cardiomyopathy. So, to start off with what's normal. So, your heart has four chambers, two upper atria and two lower ventricles, and then it has two sides, left and right. So, the left side gets that oxygen rich blood from your lungs and it pumps the blood around your body. And so that means that your organs get the oxygen that they need, and also that the blood is delivered to the kidneys. They filter it, they make your urine, and that's how you get rid of your fluid. On the right side, then, you collect the blood back from the body after it's extracted all the oxygen, and then you pump it back to the bloods to get re-oxygenated. And then you've got a number of valves in your heart as well. So four chambers, four major valves, and the valves help to make sure that the blood flows one way only and doesn't reflux back into the wrong place. You'll hear ejection fraction talked about a lot, and it can be quite confusing. So, ejection fraction means that at the beginning of the pumping cycle, you've got a certain amount of blood in your heart chamber. And when your heart pumps, it'll pump out a certain amount of that blood. And the percentage of blood that is pumped out is called your ejection fraction. And you're not looking for 100% for your ejection fraction. 50 to 55% is considered normal. And people can have heart failure even though they have a normal ejection fraction. It's not the entire story. So, what is a cardiomyopathy? Cardiomyopathy is just a very generalized term, which means that you have an abnormal heart muscle. And it doesn't necessarily mean that you have heart failure, because heart failure is the failure of your body, of your heart to meet the needs of your body, whether that is pumping enough blood around your body or getting rid of fluid. And so, how might you be diagnosed with a cardiomyopathy? Well, you may have symptoms. You may have symptoms of heart failure or other symptoms. It might be picked up during other testing, maybe if you're going for a big surgery and you need a scan of your heart. And then sometimes it'll be picked up because you have a family member who has been diagnosed with a cardiomyopathy. And the idea of family screening is to pick these conditions up before you have symptoms and hopefully avoid you ever having symptoms, because the treatments that are available are so good these days. I'm going to briefly talk about the types of cardiomyopathy, more so that you can pick up and maybe highlight the one that you have yourself if you're a cardiomyopathy patient. I will say that the majority of treatments that we will be talking about today are those for dilated cardiomyopathies, because the treatments for the other cardiomyopathies can vary widely, whereas the treatments for dilated cardiomyopathy are pretty standard. Even if you have one of the other cardiomyopathies, you may still have an overlap. And so you may have an element of a dilated cardiomyopathy or a DCM as well. And so even if, for example, you were initially diagnosed with an arrhythmogenic cardiomyopathy, you may be on the medicines that we'll talk about today. So hypertrophic cardiomyopathy is where you have an abnormally thickened muscle. And so your heart may be stiff, but you also lose space within your heart. And so your heart isn't able to hold as much blood. And so it doesn't pump as much blood around your body. You may also have rhythm problems. Dilated cardiomyopathy is where your heart becomes enlarged. And the way I think about this is like a balloon. So if you blow up a balloon and then you let all the air out, you'll see the balloon's gotten kind of floppy and it's not as elastic as it used to be. And that's what happens to your heart. Non-dilated cardiomyopathies are one of the newer types that we're looking at. And in some cases, it may be that you have a heart condition that hasn't progressed to the point where your heart is enlarged, or it may mean that you have an abnormal heart muscle and it's just not enlarged. Arrhythmogenic cardiomyopathies, again, are people who have heart rhythm problems that are affecting the function of their heart. And then restrictive cardiomyopathies typically have a very stiff heart. And so they may be some of the patients who have heart failure but have a normal ejection fraction, where their heart has more of a problem with relaxing than it does do pumping. There are tons of causes of cardiomyopathies, and we previously would have divided cardiomyopathies into what we would call ischemic and non-ischemic. And ischemic would have meant that you had a heart attack and that was what caused your cardiomyopathy. And we kind of bunched all the other causes together. With the improvements in family screening and in genetics, that is becoming a big part of cardiomyopathies in Ireland as well. And so you have people who've had a heart attack, and then you have people who have a genetic cardiomyopathy or they have a family predisposition to cardiomyopathy. Now, there are lots of other things that can cause cardiomyopathy, such as high blood pressure, problems with those heart valves, toxins, and alcohol would be quite a big one. Drugs, and these may be drugs that you are prescribed, such as chemotherapy, or they might be drugs that are not prescribed. Diabetes and thyroid problems. So, thyroid problems in and of itself can cause heart issues. Diabetes increases the risk of multiple heart conditions, including heart attacks. And then diabetes itself, if it's not well controlled, can also affect your heart. In terms of infections, you would have seen many years ago that there would have been lots of people who were told that they had a virus that had affected their heart, and that was why they'd had a heart condition. The problem with a lot of infections is there actually isn't great tests for them. And so that was kind of what people were labeled in the past. They're actually a fairly rare cause of cardiomyopathy, but there are people who pick up infections that affect their heart and therefore cause them to have an abnormal heart muscle. In terms of inflammation, so inflammation in your heart can be due to multiple different causes. You might have heard the term myocarditis, which is the kind of official term for inflammation of the heart muscle. And that can be due to viruses, it can be due to multiple other causes. It can be due to sarcoid, which is a relatively common condition in Ireland and was probably not diagnosed as frequently as it could have been previously. We now have much better tests for this condition, and so we're picking it up much more. And then again, inflammation can actually be due to some medicines as well, and some of the newer cancer medicines. In terms of pregnancy heart problems, so this would be called peripartum cardiomyopathy. And so that's where you have a heart problem that's picked up toward the end of your pregnancy, around the time of delivery, or afterwards. And what we're seeing with these cardiomyopathies, particularly ones caused by toxins, drugs, and pregnancy, is that a lot of people might have a genetic or family predisposition to a heart problem, and then they get a second hit. And so maybe the pregnancy puts a bit more strain on their heart or the medicines that they're on. And so, there may be some people who can have a couple of drinks, fairly frequently, and it doesn't affect their heart at all. And there are some people who just can't, unfortunately, because their heart is at risk. And so they get two hits to their heart, and that causes them to have a cardiomyopathy. It's important to try to work out why you got a cardiomyopathy, because if you know what caused it, you can try to fix the underlying problem or address the underlying problem and hopefully help to make it better. So we've talked about cardiomyopathy, i.e., an abnormal heart muscle. But what is heart failure? And so the heart has two main roles. Number one, it pumps blood to the kidneys. The kidneys get rid of the fluid, and so it stops you building up fluid. Number two, when that blood pumps around your body, it delivers oxygen to your organs. And so if the heart is not doing either of those jobs well enough, then you have heart failure. Heart failure may affect the left side of your heart, the right side, or both, although it's more commonly affecting the left side. And you may have a squeezing problem where your heart doesn't squeeze, or your ejection fraction is low. Or it may be a relaxing problem where your heart is stiff, and we call that heart failure with preserved ejection fraction, or HEF-PEF. And so, what symptoms might you have from heart failure? So, the classic ones that we all are aware of are shortness of breath, swelling of your legs, and then particularly shortness of breath when you're lying down and that fluid has more of a chance to back up into your lungs. Fatigue can be a really huge part of heart failure, and a lot of our patients would struggle with fatigue, and we have some things to help with that. Coughing or wheezing may be an issue, and you might hear sometimes of someone who gets diagnosed with a cardiomyopathy having had 5 or 6 courses of antibiotics and steroids for a chest infection that they just can't shake. And most people who have cough or wheeze don't have a cardiomyopathy, but some people do. And so, in people where the treatments aren't working, the antibiotics aren't working, the inhalers aren't working, sometimes the GP might look to see is there another cause that could be causing the problem. Dizziness or lightheadedness can be another symptom. If people have a lot of fluid buildup, then they can have problems with their gut being kind of swollen and being somewhat edematous, which means that it's kind of retaining fluid. And so this can cause you to have problems with a lack of appetite and nausea. And then people can also have palpitations or racing hearts. And so, if you think that someone might have a cardiomyopathy, what tests should you get? And we're in some ways lucky these days that there are an absolute plethora of tests available, and not everyone needs every test, but it's important that if you do need a specific test, that you have access to it. And so, in terms of basic testing, your doctor should talk to you and get your history, specifically asking about those causes of cardiomyopathy that might apply to you, and maybe about your family history as well, and then examine you to see, do you have evidence of heart failure? NT-proBNP is a blood test that is elevated when you are retaining fluid, and it can be really, really helpful in terms of a screening blood test, particularly if someone has shortness of breath and you don't know why. And so this can be a really great test. We can also follow it when people have been treated for their heart failure to see, are we doing a good job and is it getting lower? We check your kidneys and your livers because, again, the heart pumps blood to all the organs of your body. And so we want to see, are those organs working well? Are they getting enough blood flow? But also, are we getting rid of fluid? Because the heart can cause the kidneys and the liver to be abnormal for either of those reasons. We'll check for anemia because in people who have heart conditions, they can have anemia and that can make them feel much worse. And then I'll have a slide later on talking about whether or not you should consider genetic testing. In terms of the electrical activity of the heart, everyone should have an ECG, which is where they put the stickers on your chest and they check the electrical activity of the heart. And then in some people, they may need a Holter monitor where they wear those electrodes for 24 hours or a little bit longer to see do they have heart rhythm problems. In terms of getting imaging of your heart, we start with an echocardiogram, which is the ultrasound of your heart. And then in some people, we'll get an MRI. And so, why might we get an MRI over an echocardiogram? Well, an MRI is really, really good at looking at the actual heart muscle. And so, if we're concerned that there might be a specific cause of weakened heart muscle, or sometimes if we can't see your heart very well with an echo, then we might be able to take a closer look to see if there's another cause that we haven't found before. When we think about the heart, we can think about the electrics, the pump, and the plumbing. And so the electrical activity is with your ECG and your Holter. The pump is looking at the echo and sometimes the MRI. And then the plumbing is the blood supply. And so in more and more people, we are now able to use a CT coronary angiogram to screen for blockages or heart attacks that have caused the reduced heart function. And then in certain people, we may go on to do a cardiac catheterization, which is where the doctor will actually put a little tube up into the blood vessels that supply your heart and take some pictures with dye. In terms of exercise testing is very helpful for a couple of reasons. First of all, it can look for rhythm problems with exercise. Secondly, it can be helpful to give you some guidance on what you can and can't do in terms of your exercise. It can also give us some information about prognosis, about how worried we should be about you. And then there are specialized exercise tests where, again, we have someone who we don't know why they're short of breath, and it can try to tease out why that might be. So as you can see, there's tons of tests that are available these days. And again, not everyone needs every test, but we're very lucky that we have multiple different ways to look at the heart function in the current times. And so why are we doing these tests? What's the goal of testing? So number one, is my heart muscle actually abnormal? And so maybe you've been sent for screening and you don't know if you've got an abnormal heart muscle, or maybe you've had another test that queried whether you have an abnormal heart muscle and the testing has confirmed this. And then you want to see if the heart muscle is abnormal, is that having an effect on your heart function? Yes or no? And if so, why? In terms of heart failure versus cardiomyopathy or abnormal heart muscle, you want to know, is my heart meeting the needs of my body, or do I have evidence of heart failure? And then finally, we want to know what treatments are available. And there are more tailored and specific treatments for specific cardiomyopathies. So if you know why it happened to you, then you can hopefully get individualized treatment. So, just a very quick note on the need for family screening. And so, why might you be sent for family screening? Well, there are certain types of cardiomyopathy where it is recommended that if you have it, you get family screening. And so, one example might be hypertrophic cardiomyopathy. If you are diagnosed with a dilated cardiomyopathy, you may say to your doctor or your nurse when you're going in to be assessed, well, my dad had a weak heart, or, my brother or my sister had a weak heart, or there may be someone in your family who died suddenly. And again, in years gone by, they often would have been labeled as having a heart attack. But if you don't know, then sometimes it may be that they had a weakened heart. And so if a family history of cardiomyopathy is picked up, then it's a good idea to get family screening. And so when it comes to family screening, we are still working on the availability for this in Ireland today. But oftentimes it will start with genetic testing, which is a blood test of the person who has been diagnosed with a cardiomyopathy. And this is helpful because if we do find a gene, then your family members, your first degree family members, can also just get a blood test. And if they don't have the gene, then they don't need a scan of their heart. If we don't find a gene, then your family members may need to have a scan of their heart to see if they have a cardiomyopathy. And again, the treatments are so good these days that if we pick folks up early, then we can get them on treatments nice and early and hopefully stop them ever developing heart failure. So I'm going to go somewhat briefly through treatments for cardiomyopathies and heart failure, because I know that this has been covered in other talks. Some of the goal of this is to help you understand why we choose certain treatments, because I think knowledge is power. And if you know why you're on a treatment, then hopefully it will help to kind of be engaged with it and to maybe put up with some side effects, which can be a little troubling at the beginning. So, when you have heart failure, you have two major hormone systems that are activated in your body. And so the first one is called your sympathetic nervous system, which is your fight or flight, means that you're running from a bear. And so this puts stress on your body and it puts stress on your heart. The second one is the hormones in your kidneys, and these hormones can cause you to retain fluid, to retain salt. And over time, both of these hormone systems will result in your heart becoming enlarged and the heart function becoming more reduced and potentially cause scarring of the heart. The medicines that we have available specifically for dilated cardiomyopathy block these hormones. And these medications don't just improve your quality of life and make you feel better, they also make you live longer. And it is truly a golden era of heart failure therapies. The medicines that we have available these days are a world better than they were even 10 years ago. And so you may have heard the term the four pillars. And so this is what's called guideline directed medical therapy, where we try to get patients on all four medications, which we will discuss. And we additionally try to get people up to the maximum possible dose because we have evidence from trials to show that the higher the dose that we can get you on, the better the benefit that you will have. And so we're going to talk about beta blockers, ACE inhibitors, angiotensin receptor blockers, and ARNIs or Entresto, aldosterone antagonists, and then SGLT2 inhibitors. So, beta blockers are the medicine that targets that sympathetic nervous system. And so they slow down your heart, they reduce the work on your heart, and over time, they can improve your heart function. There are lots of beta blockers available, but the ones available in Ireland that are specifically studied in heart failure are bisoprolol and carvedilol. Now, they can have some side effects. Again, these side effects tend to get better with time, but people can have some tiredness. They can feel a little bit dizzy. They can feel a little bit cold, and you may have a slower heart rate. The slower heart rate may mean that the dose has to be reduced of your beta blocker, but we focus a lot on how you're feeling. So there are plenty of people walking around with a heart rate of 40 or 50 who feel absolutely fine. But if you're not one of them, then we can reduce the dose to try to help you to feel better. When it comes to ACE inhibitors or angiotensin receptor blockers, they're one of the medicines that target those hormones in your kidneys, and they relax your blood vessels and basically take the pressure off the blood vessels so that your heart doesn't have to pump as hard. And again, over time, these improve your heart function. As you can see on the second column, there's lots of different medicines available in these classes. In terms of side effects, one of the side effects of ACE inhibitors is a dry cough, and this might be a reason why you might be transitioned over to an ARB or an angiotensin receptor blocker. People can feel a little dizzy at the beginning of being on these medicines because their blood pressure is lower. Again, this does tend to get better with time. We do need to monitor your potassium and your kidneys, and there is the possibility of having facial swelling due to these medicines, which is very rare. But if you do develop lip or facial swelling after being started on these medicines, then you should let your nurse or doctor know. So Entresto is a relatively new kid on the block, and this is a mixture of an angiotensin receptor blocker with another medicine. And that other medicine called sacubitril, it increases the good hormones in your body. So it increases those hormones that get rid of fluid, that reduce the stress on your heart. And so this is a superior medicine to those ACEs and ARBs and is available for people who have an ejection fraction of less than 35%. In terms of things to know about these, they have similar side effects to the ACE inhibitors or angiotensin receptor blockers. And if you're being switched over, if you're on an ACE inhibitor, you need to have a break of a couple of about 36 hours before you can go on to the Entresto. But our nurses are experts at transitioning people over. And so if you're a candidate for this medicine, it's really great to be able to get on it because it has great benefits. So when it comes to the mineralocorticoid receptor antagonists, these are your spironolactone or your eplerenone, and they also work on the kidneys. Now, these medicines are great in terms of helping you to live longer, helping your quality of life. They have similar side effects on the kidneys, and so we need to watch out for those. In men, you can have increased breast tissue, which is called gynecomastia, specifically with spironolactone. And so if you get kind of sore breast tissue or enlargement after starting this medicine, you can let your team know and switch over to eplerenone. Some of you may be on diuretics to help get rid of fluid and have to take potassium supplements, which can be not very nice medicines to take. And the nice thing about the spironolactone and the eplerenone is that it actually keeps the potassium up, so it can reduce the doses of potassium that you might have to take. And then the last major pillar is your SGLT2 inhibitors. And so these are medicines that were developed for diabetic patients. And the way that they work is they make you pee out sugar. And they found that in the trials for these medicines, the people weren't being hospitalized as much with heart failure. And so they then made big trials to have a look and see if they were actually beneficial in heart failure. And it turns out that they were. And these are great medicines because they have really minimal side effects. It's one dose, one time a day. You typically don't have lower blood pressure with them. They can help to get rid of a little bit of fluid. And usually people don't even feel very different when they're on these medicines, apart from the fact that their heart function gets better. Now, in terms of side effects, there's two major ones to be aware of. The first one is a slightly increased risk of urinary tract infections because you've got sugary pee. And the second one is what we call sick day rules, where you shouldn't take these medicines if you're fasting or you're otherwise sick. Now, briefly to talk about other medicines that are used. So diuretics are medicines that get rid of extra fluid through peeing it out. And so these medicines can help to keep you out of the hospital. They don't make your heart function better and they don't make you live longer, but they can make you feel significantly better and they can keep you out of the hospital because of fluid buildup. And so we need to watch the potassium, the magnesium, and the kidneys on these medicines. Ivabradine is used for people who have a fast heart rate. And so maybe some people might be on a beta blocker, but they still have a fast heart rate, or they might not be able to take a beta blocker for some reason. And so in those patients, they can go on ivabradine. It makes their heart beat a little slower and it reduces their risk of coming into the hospital. And so, when it comes to guideline directed medical therapy for heart failure, it really does improve quality and quantity of life. And side effects do usually get better with time. And so, the way that we like to think about it is similar to chemotherapy. We know that chemotherapy can be tough, but we know that there are massive benefits if you stick with it. Our guideline directed medical therapy is not associated with half as many side effects as a lot of chemotherapies, and it's associated with really tangible, true benefits, not only in how you feel ultimately, but also how long you're going to live and if your heart function is going to get better. And so we'd really encourage people to try to stick with their medications for a number of months, keep in with the heart failure nurses, and try to get up to as good a dose as they can because their benefits are real. Now, I'm going to talk a little bit about other treatment options that might be considered for people with cardiomyopathies, because you may notice on one of these slides that you have this problem and you can see if it's an option for you. So I know that there's going to be a talk in this series about pacemakers and defibrillators, so I won't talk too much about it. But pacemakers can be used when your heart is beating too slowly, and defibrillators are what we call an insurance policy. If you have weakened heart function or if you have an arrhythmogenic cardiomyopathy, you are at risk of abnormal heart rhythms that could ultimately be a cause of death. And if you see people in the movies or in TV shows getting shocked with pads, that is what a defibrillator does if it is implanted into your chest. And so it would treat a heart rhythm which may otherwise be fatal. So we utilize these in people who have weakened heart muscle despite the medicines, or in people who have specific heart muscle problems. Now, cardiac resynchronization therapy, which is also called a bivent or CRT, helps when the electricity is moving too slowly across your heart and causing it to beat inefficiently. And so that helps the different parts of your heart to pump together and can also help your heart function. And so we recommend these in specific people who have that problem. Now, therapies for your heart that are done through the leg or through the arm are becoming much more common and much more widely available. And specifically for heart failure, on the left side of the heart, the mitral valve is in between the atrium and the ventricle. And if your heart becomes enlarged, then that valve can start to leak. And that causes blood to leak back into your lungs, which can make you feel very short of breath and can also make you build up fluid because that blood is not going back to your kidneys to be filtered out. A mitral clip is a very small device that you can see a picture of here that helps the valve to close better. So it clips two parts of the valve together, and sometimes you might need more than one clip, and basically helps to reduce that leakage. And so that can be used in people who are on medicines, but either the medicines aren't doing a good enough job at reducing that leakage, or they still feel very short of breath. You can see if that valve is leaking and see if you're a candidate for the clip. In terms of stents or bypass, specifically in people who have blockages of their artery, so a plumbing problem that's causing their abnormal heart muscle, restoring proper blood flow to the heart can help to improve the heart function. And so your team will give you a recommendation as to whether a stent is a good idea for you. So a small tube to open up that blockage, or surgery. And so surgery can be used sometimes if there's multiple blood vessels that need to be opened, or if you've got blockages in specific places in your arteries, or if you've got other medical problems that mean that surgery is a better option for you, such as diabetes. When we talk about AFib, so there are plenty of people who have atrial fibrillation. And so that's an abnormal heart rhythm that comes from the upper chambers of your heart. But in certain people, it can be the cause of their weakened heart muscle. And so there's more and more evidence coming out that people who have abnormal heart muscle or who have heart failure and who have atrial fibrillation should be considered for an ablation, where they block those electrical impulses that cause the AFib and restore normal heart rhythm to the heart. And these ablation procedures are becoming more widely available. They're becoming quicker and they're becoming easier in order to access them. And there are specific doctors who are able to offer these for you. Now, iron and heart failure. So we spoke about fatigue. And so when you have heart failure, you don't absorb iron very well. And we know that if we detect low iron in people with heart failure, and if we supplement it, that it can make you feel much better, less short of breath, more energy, and it actually can reduce your chance of being hospitalized as well. And so, in patients who have heart failure and who have low iron, the first thing to note is that you can have low iron even if you don't have anemia. And so, the threshold for needing to replace iron is different in patients with heart failure compared to regular patients. And so, your heart failure team will be aware of those thresholds and they'll check your iron periodically. The next thing to be aware of is that iron tablets are not well absorbed in people with heart failure, and they often lead to a lot of side effects, including constipation. And so we use a lot of iron infusions because it's a once off infusion. You can get checked again in a couple of months to see has your iron come up. And we hear from people that they feel significantly better. So I've spoken a lot about getting medicines up to maximum doses, about getting iron infusions, and who is the team that organizes all of this? Well, it's really the heart failure nurse specialists, and they gave me some of the slides that I'm using today. And so our heart failure nurses really are the backbone of our team. They provide education, they can provide a helpful ear to help you know if your symptoms are something you should be worried about or not, how to manage yourself, how to monitor yourself, and they do a great job in getting you up to those maximum tolerated doses of the medicine to try to get the most bang for your buck. So I can't plug them enough. So we'll move on to self-care. So how can you help to find success in your heart failure journey? First thing we would say is that small changes can make a big difference. So, sometimes it can feel quite overwhelming when you get diagnosed with heart failure and you suddenly got all of these new medicines. You're being told about fluid restrictions, about exercise, but a little bit of a time can be really helpful. And it's not an all or nothing approach. If you can do little things to help your lifestyle, then you can have big benefits from them. And so why do we prescribe heart failure regimes? Well, we do this because we know that it can help you to not be hospitalized with heart failure, hopefully not have another heart attack if that's the reason for your heart problem, and hopefully to help you live longer. And so we want our patients with heart failure not just to survive, we want them to thrive. We want them to have a great quality of life and a life as close to normal as possible. And keeping on track and trying to follow some hopefully easy and simple lifestyle recommendations can really help for this. And again, it's all about finding what works for you. Not everyone is going to be able to go to the gym 7 days a week to eat, a perfect diet and to have no vices, but any positive changes are great. So in terms of weight monitoring, so one of the main things about weight monitoring is just about routine. So if you weigh yourself every day at the same time, in the same clothes, maybe just after you've gotten out of bed, you've gone to the bathroom, you haven't eaten anything. And so it should just be part of your routine, like going to the bathroom, brushing your teeth. And so if you know your dry weight, then you'll know when your weight is becoming a problem from a fluid point of view. And so the easiest way to know this is oftentimes the weight that you get discharged with when you're leaving the hospital if you've had a heart failure hospitalization. We recommend recording your weight in a diary. And essentially, the thinking is that it's very, very difficult to put on, 2 kilos of fat in a day or 2 kilos of muscle. Certainly, women can have hormonal related kind of changes in their body weight. But if you're having a very rapid weight gain, then it can be a sign of fluid retention. Or if you're having a slower weight gain, but the weight is continuing to go up, then it is important to be assessed to see if you're starting to retain fluid. And oftentimes, this can be associated with symptoms like you're getting swelling, like you're getting more short of breath, and maybe more short of breath when you're lying down. But sometimes, if you manage to pick up the weight gain before the symptoms, you can intervene and take a couple of days of extra diuretics as guided by your team before you develop any symptoms. It can be difficult to work out what the type of weight you're gaining is. And so that's another reason why going with symptoms as well as the weight, putting everything together can be helpful. Realistically, we find when people have first been diagnosed, they really don't know what their new normal is, and they might contact us a little bit more with concerns, with queries, and that is totally fine. That is totally normal. You'll get to know your own body, you'll get to know what a good fluid status is for you, but it's a learning curve both for us and for you. In terms of fluid restriction, so the data on fluid restrictions actually is a little controversial, and you may get different advice depending on where you're being seen for your heart problem, and that's absolutely fine. But in general, you should avoid really excessive fluid intake because everything that you drink, your body has to get rid of, and your heart has to get rid of. In terms of a couple of things that we see for issues, you have to include all liquids consumed. So it's not just water, it's water, tea, coffee, soup, everything. And so it's helpful to spread your drinks out over the day. In people who are really struggling with this, sometimes they might get a couple of 500 ml bottles of water and just fill them up at the beginning of the day. And then they know that's what they have to drink, and they're not trying to do maths, try to keep diaries, try to work things out. But again, over time, you'll get to know what is what. You'll get to know if I have a cup of tea, that's 400 mils. If I have a can of Coke, that's 330. And then you'll know roughly what your balance is and if you're drinking too much. And so some people can really struggle with thirst, and that's not just because they're restricting their fluid, but it can also be because the water tablets can make you feel a little thirsty. And so how can you help with this? So rinsing your mouth can be one option, brushing your teeth. Sour things or things that make you make saliva can be really helpful. So people sometimes have sour sweets or lemon slices. They use mints or chewing gum. And some people find that the colder things are, that the more refreshing they are and the more they help with thirst. So sometimes you might get your MyWadi and make it into ice cubes. You might have a Calippo. And once you're including it in your fluid allowance, then that's absolutely fine. Some people also freeze their fruit and they find that that helps a lot as well. So alcohol is a toxin to your heart. And so it can be the primary cause of heart muscle problems, but it also increases stress on your heart. And so, in general, the recommendation for people who have a cardiomyopathy is to really limit alcohol as much as possible. And if there is any question of alcohol being a player in the cause of your cardiomyopathy, you should absolutely abstain completely because you're just continuing to give that insult to your heart and you're just attacking the heart muscle. And so, if at all possible, then abstinence is best, but definitely everything in moderation and minimization. So smoking and vaping, and so smoking really does increase your risk of having a heart attack. But more importantly, stopping smoking is so beneficial. And so if you've been off the cigarettes or the vapes for a year, then your risk of a heart attack has halved. After 10 years off cigarettes, your risk of death from lung cancer is halved. And if you've been free from cigarettes for 15 years, your risk of heart attack is the same as someone who's never smoked. We'll talk a little bit in subsequent slides about needing other therapies for heart failure and how smoking can be a problem for them. And so I cannot stress enough, if you are smoking, try to do everything, try to take any resources that are available to try to help you because it will be one of the best things that you have ever done for your health. Vaccinations. So the problem with cardiomyopathies is that if you get the flu or if you get COVID, then your risk of becoming seriously unwell is higher than a person who does not have a cardiomyopathy. And so we do recommend annual flu and COVID vaccine. And then you can ask your GP about the pneumococcal vaccine. There's two available. And so we strongly recommend that people get these vaccines because they, again, if they get sick, then their risk of having a heart failure exacerbation alongside the infection is higher. Now, resting. So do schedule time every day for rest and relaxation. Having a cardiomyopathy or having heart failure can be really stressful. And so if you try to acknowledge that and try to find mindfulness or try to find peer support similar to the amazing resources that are offered by the Irish Heart Foundation, then you can help with this. In terms of practical things, Don't take your last dose of diuretic at 8 o'clock in the morning. In general, the diuretics can be taken first thing in the morning and then around lunchtime so that you get a good night's sleep in. We talked a little bit about managing stress, and this is one of those things that I think is easier said than done, and something that we as doctors might say, but not have great tools to help with that. And again, that's something where the Irish Heart Foundation can come in to try to help you in terms of resources, peer support, knowing that you're not alone. And so, when should you seek help? So, the symptoms that we spoke about, coughing or phlegm, sudden weight gain, weakness, or other new or unexplained symptoms. And so, again, at the beginning, when you've just been diagnosed, you don't know what your normal is, and you may need to reach out to your team a little bit more frequently. You may need to reach out for support, and that's absolutely fine. But if you have any of these symptoms, then do seek medical attention and you'll get advice as to whether you can maybe come in for an appointment, maybe see your GP, see your nurses, or whether you need to go to the emergency department. Now, one of my last plugs is for cardiac rehab. And so, cardiac rehab is amazing. So, it is medically supervised exercise and it's helpful for multiple reasons. It doesn't just increase your fitness or increase your functional status, it also increases your mood, your quality of life, your risk of coming into the hospital, and your risk of having a heart attack. And people find that they develop not only increased fitness, but they also have increased confidence because they know what they can do safely because they're being monitored. They have solidarity with other people who are in the same boat as them. There's psychological support and lifestyle education. And so it really does help multiple facets of your heart failure management. Now, not everyone can do cardiac rehab. It is a big commitment. And so if you can't do cardiac rehab, Xwell is another phenomenal resource. And so Xwell is set up by Noel McCaffrey, who's a cardiac rehab guru. And they have multiple different areas all over Ireland where they have basically, medically supervised exercise classes. They really try to find a way to make it work for everyone. So, whatever your level of mobility is, whatever your symptoms are, they will try to make it work. The classes are heavily subsidized, and so they are hopefully not too expensive. And as you can see here, they have tons of different places where you can go and hopefully get some improvement in your functional status. And so you've gone through all of these treatments. You've gone through medication titration. You've had your iron replaced. You've done cardiac rehab. And so once you've had this period of time of optimization, you should have a repeat set of testing. And so when you have this testing, you can ask your team, has my heart function improved? And if it's improved, then, is it back to normal? Is it still reduced? Or what level am I at? If it hasn't improved, are there other things that can be considered? So, for example, sometimes we increase the medicines as much as possible, and then we consider that specialized pacemaker, or we might consider the mitral clip. So, there's other things that can be tried if the initial steps haven't worked. And then the last thing to say is, even if you have reduced heart function, there are plenty of people who are living with reduced heart function, who are living really excellent quality lives. And so your heart might not be perfect, but is it good enough for you? Is it meeting the needs of your body? And so that may be the case for you. And so the last thing I'm going to talk about, just because of my specific role in heart transplant and advanced heart failure, is going to be when you may be struggling. So whilst the medications are brilliant, whilst the treatments are fantastic, there are certain people who unfortunately won't respond to them. And so if you are coming into the hospital very, very frequently, if your kidneys and your liver aren't doing well, if you are having shocks from your defibrillator, if your blood pressure is very low, and if your team is having to pull back on the doses of medicines because of low blood pressure or because of your liver or your kidneys not doing well, then it is reasonable to ask, should I be referred to a heart failure specialist? And so when we see people in our advanced heart failure clinic, we'll consider two main therapies. The first one is heart transplant, and then the second one is a pump called a left ventricular assist device, which takes over the work of the left side of the heart. And so I think it's outside the constraints of this talk to talk about these therapies today, but We are always happy to hear about patients and we welcome referrals for these therapies. And again, our goal with these therapies is to help people live not just longer, but have a really great quality of life. Now, when it comes to these advanced heart failure therapies, there are two modifiable things that we hear again and again, and that can be a reason why people aren't able to have these therapies. And so the first one is smoking or vaping. So any nicotine related substances for 6 months before these therapies is an absolute no-no. And then the second one is obesity. And so for transplant, the BMI cutoff is 30, and then it is a little bit more relaxed for LVAD, but in general, it still needs to be taken into account. And so as you probably know, there are treatments available for obesity now that have made it a much more manageable disease. And so if you are still smoking, and you have significantly reduced heart function and you're wondering whether these things might be an option for you in the future, really do try your best to stop. So to finish up, there are multiple causes of cardiomyopathy, and if at all possible, it's really important to try to work out why this happened to you, because the treatment can be slightly different depending on the cause. Treatments for heart failure have truly improved, and we refer to this as the golden era of heart failure therapy. And so the medicines help you live longer, improve your quality of life, and they are miles ahead of where they were a number of years ago. If you are educated about your heart condition, if you are able to help manage yourself, monitor yourself, and hopefully live as healthy a lifestyle as possible, then you can hopefully look forward to a really good prognosis with a kind of a combined targeting from your team and also from yourself.